So this is only the first course. We will make some considerations about the basics of echocardiography, and later on you will have a second one on cardiac pathology, valvular lesions, and the most frequent diseases in cardiology. You know by now that echocardiography is the most frequently used technique, and that's because it has a lot of advantages over other techniques that we may use, and those are CT and MRI. Echo is widely available. We have portable devices now. We can perform bedside echo. We also have some small devices that we can use as a handheld device because these are as small as a smartphone. It's an easily repeatable exam. It's a non-invasive one. It poses no risks to the patient, especially if we are talking about thoracic echocardiography, because in transesophageal echo, we have some problems, we have some minor complications. The patient is not exposed to radiation, and this is a major advantage. It has a low cost, and it's a portable technique. And it also allows the assessment of cardiac dimensions, ventricular, valvular function, valvular morphology, and a non-invasive assessment of pulmonary pressure. Also, it is important to say that it can be performed in any cardiac rhythm, whatever the heart rate of the patient. It has also some disadvantages. It is operator dependent, and it depends also of the patient. We have some patients in whom the acoustic window is not suitable to an accurate exam on echo. So we have to use other techniques in these patients, but there are a few patients in whom we cannot use echo. Very obese patients, for example. What are the data offered by echo? Echocardiography offers a lot of data regarding the structure of the heart. We can see all the cardiac chambers. We can measure the ventricular and atrial dimensions, and these are important elements when considering surgery in some patients, as we will also see in the courses later on. We can measure the linear dimensions and also areas and volumes. We can see the valvular structure, the number of cusps at the level of the aortic valve, for example, to diagnose bicuspid aortic valve. The leaflet morphology, we can see if the leaflets are of normal size and thickness, or if they are thickened, the degree of opening and closure. We can also estimate the dimensions of the vena cava, which is important in estimation of right atrial pressure, and also the septum integrity, both the interatrial and interventricular septum. And we can see if the pericardial fluid is present or not. We can also see if the ventricles are functioning right. We can estimate the systolic and diastolic function of the left ventricle and also the systolic function of the right ventricle. We have also a lot of data regarding valvular function. We can see all the full valves of the heart, and using Doppler echocardiography, we can estimate valvular stenosis and regurgitations. And it's also very important to say that we can estimate pulmonary pressure. We can have an idea about the pulmonary pressure because we have to confirm the pulmonary hypertension by cardiac catheterization when this is needed. And the agenda today refers on some considerations regarding the bidimensional echo. We have to see what are the standard views from the most frequently used windows, acoustic windows in every patient, and some data regarding the Doppler echocardiography. Today we are discussing only about the normal Doppler flow patterns And this lecture is used for you to be familiar with those acoustic windows because they are used in our presentations later on, both at the lectures that we have to sustain and also on practical demonstrations. So the heart is of course a 3D structure, and the most frequently performed echo is two-dimensional. So these 2D standard views, you can see as thin slices through the heart, and you have to integrate all the information into space. All the acquired data must be integrated in order to obtain a full image of the heart. So practice matters, and it matters also is that you can know the details, the anatomical details of the heart and great vessels, and this is an advice for you to read these notions that you've done at the anatomy course regarding the structure of the heart and the great vessels. So in echo, you must know where you are and what you see, and that's why we have standard views. What about the echo machine? You have to know that we performed echocardiography with this kind of probe, with this sectorial transducer, which has a small footprint and a low frequency that is required to ensure a good penetration. It has a 2 to 4 megahertz frequency versus these probes that we use in the abdominal echo and in vascular echo. So this probe is different. And the echo image is obtained by using the interaction of ultrasound wave with the tissues. So as the beam of ultrasound travels through a material, through the tissue of the heart, various processes happen to it, and the most important one is the reflection of the beam, which is called an echo, and this is a critical concept in all diagnostic imaging. So we interpret these images that comes from the body after the ultrasound wave penetrates it, and then it reflects back to the machine. We have two major types of echo imaging. We have 2D echo, that is a structural imaging, and we can see the structures. It's a grayscale imaging. You have to keep in mind that the best image in 2D, in two-dimensional echo, the best quality of the image is obtained when the ultrasound beam is perpendicular to the structure that is to be examined. So in this view, which is a parasternal long axis view, you can see the left ventricle, the walls of the left ventricle, and you can easily measure these walls. On the contrary, in this apical window, we cannot measure the walls of the left ventricle, but because we are using this window to see the valves, which are perpendicular to the ultrasound beam, and we are measuring the walls in this window, and we can better see the valves in this one because we are perpendicular to the valves. On the other hand, Doppler echocardiography is a functional imaging technique. The best image of in Doppler is obtained when the ultrasound beam is parallel to the flow this time. So we cannot interrogate this jet here of aortic regurgitation because we are perpendicular to the jet, but we can easily interpret and measure the flow through the mitral valve from this apical window when the ultrasound beam is better aligned with the flow. And these are the most frequently used standard views. We start in every patient with the left parasternal views. Then we perform the apical views the subcostal view, and the suprasternal view. And in some patients, we need also to examine the patient in a right decubitus position to see the right parasternal view. This is the most important. This is most important in patients with aortic stenosis, because we can align with the flow through the aortic valve in this position. And also in patients with suspicion of aortic dissection, because we can easily see the ascending aorta from this right parasternal view. So we will start with the parasternal long axis view. In this view that is obtained from the left parasternal intercostal spaces with the patient in the left decubitus position. In these intercostal spaces, 3, 4, 5, it depends on the patient and on his anatomical structure of the thorax. We can obtain this image in which we see the left ventricle in this long axis view, the aortic valve here, and a small segment of the ascending aorta, and the left atrium. And between the left atrium and the left ventricle, of course, a mitral valve. And anteriorly situated in this view is the right ventricular outflow tract here, that is the most the nearest structure to the probe. And this is the parasternal long axis view in a normal subject. In this image, in this movie, you can also see the opening of the mitral valve and of the aortic valve that opens widely in this patient. We can see the left atrium. We can measure the anteroposterior dimension of the left atrium. We can see LA masses if they are present. And we can make considerations about the mitral valve, about the morphology of the mitral valve, the degree of opening, closure, the papillary muscles, and chordae if they are seen. They are seen here as they attach to the leaflets of the mitral valve and to the ventricular wall. In this patient that had a mitral stenosis, you can easily see that the mitral valve is not opening fully. So it's a thickened mitral valve. And you can see by the 2D image that this patient has a mitral stenosis. The cusps of the aortic valve are also thickened, thicker than normal, and the left atrium in this patient is severely dilated. You can also measure the left ventricular walls. From this parasternal long axis view, we image the anterior interventricular septum here and the inferolateral or posterior wall. And you can measure the thickness of the walls. We measure the thickness of the left ventricular walls in diastole. You can easily see that echo images are obtained also using the ECG of the patient, because it's important to see the timing of these measurements. And we can measure, as I said earlier, the left ventricular walls are measured in diastole on the R wave. This is a normal subject, and this is a subject with aortic stenosis, and you can easily see that the walls of the left ventricle, both the septum and the posterior wall, are thicker than normal. And you can also see the aortic valve. There are the two leaflets in this window, the right one here next to the right ventricle, and the posterior one is either the left coronary leaflet or the non-coronary leaflet. And you can see the degree of opening and also the thickness of the cusps and calcifications if they are present, like in this patient with aortic stenosis that had a calcified aortic valve. And the left ventricle here above the right ventricle here above the left ventricle. You can see the right ventricular free wall, and you can estimate the dimensions of the right ventricular outflow tract. This is a parasternal long axis view with color Doppler. This is a normal color Doppler flow in this patient. The red color signifies that the blood is moving towards the transducer. The transducer is here. And the blue means that it travels away from the transducer. So you can see this alternation of blue and red, and no turbulent flow can be seen from this normal subject. By rotating the probe 90 degrees clockwise, you can obtain some sections that are perpendicular to this parasternal long axis view. These are called the short axis views of the left ventricle at the level of the great vessels, at the mitral valve, at the papillary muscles, and further away at the left ventricular apex. And this is the parasternal short axis view at the level of the great vessels. In the center of the image, you can see the aortic valve with all the three cusps. This is the right cusp of the aortic valve. This is the non-coronary cusp that's next to the interatrial septum, and the left coronary cusp. And in some subjects, you can also see the left coronary arteries, the main coronary artery that has the origin here at the level of this valsalva sinus of the aorta. So it's the aortic valve in the center, and this is the right ventricular outflow tract, and this is the pulmonary valve here, the right atrium and the left atrium, because we've made a section that's perpendicular to this view. So we can see the right ventricular outflow tract, the aortic valve, and then the left atrium. We can estimate the dimensions of the left and right atria, but we do not perform measurements here. You can also see the interatrial septum here, and if the patient has an ASD, an atrial septal defect, you can see the flow in Doppler color Doppler flow from the left atrium to the right atrium. And you can also see the pulmonary valve and main pulmonary artery and measure the pulmonary artery. In the parasternal short axis view at the level of the mitral valve, you can see the morphology of the mitral valve, the degree of opening and of closure. And in patients with mitral stenosis, like in this patient, you may perform a measurement that is called the mitral valve area, the planimetric area of the mitral valve, by measuring this area, but you have to be sure that you are at the level of the mitral leaflets that opens very poorly at the edge of the mitral leaflets, and that the smallest orifice is obtained. You can also see the basal segments of the left ventricular walls, and you can analyze the thickening of these walls in systole. This is a normal subject and the subject with mitral stenosis. The parasternal short axis view at the level of the papillary muscles, you can see the contractility of these mid segments of the left ventricular walls. You can also measure the left ventricular cavity here, and you can see the papillary muscles. This is the anterior one, and this is the posterior one, the posteromedial one, and the anterolateral one. And also you can see the right ventricle here. The M mode, this is a technique used for mobile structures because it has a high temporal resolution. What we can do, we can perform on M mode through these structures to easily see the movement of the left ventricular walls and the mitral valve, because this mode has a high temporal resolution. And parasternal short axis view at the level of the apex. You can estimate contractility of the apex. You can see if there are any masses there or a thrombus in the left ventricular apex, as it happens in patients with dilated cardiomyopathy or in patients with an apical aneurysm, where thrombi can form at the level of the apical segments. And there are also some left parasternal modified views in which we can see the right cavities of the heart. This is the long axis view of the right ventricular inflow tract. So this is the right ventricle and the right atrium and the tricuspid valve. Here this is called the inflow tract of the right ventricle, because we see the tricuspid valve. So it's the right ventricle in the segments that performs the inflow motion. So this is where the blood comes from the right atrium through the tricuspid valve to this ventricle. In the other windows, in this one, you can estimate the right ventricular outflow tract. So this is the inflow view of the right ventricle, and this is the outflow tract view, where you can see this portion of the right ventricle that performs the ejection of the blood into the pulmonary artery, that can be seen here. This is the pulmonary valve, the pulmonary artery, and the outflow tract of the right ventricle. The apical sections, starting with the apical four-chamber view from the fifth left intercostal space on the anterior axillary line. This is a view offering the image of all the four chambers of the heart, the atria here, and the ventricles. This is the left ventricle that has a bullet shape, and this is the right ventricle, which has a triangular shape. The right atrium, the tricuspid valve, the left atrium, and the mitral valve. This is a normal subject. And this is a subject with dilated cardiomyopathy. You can see the globally dilated left ventricle, the poor thickening of the left ventricular walls, and here there is a thrombus at the level of the left ventricular apex. All the chambers are dilated, not only the left ventricle, but also the left atrium and the right atrium and the right ventricle, which has also a poor systolic function, the right ventricle, as opposed to this patient that was a normal subject. You can measure the volumes of the left atrium and right atrium, and you can assess the dimensions of the right heart chambers. The interatrial septum, you cannot diagnose an atrial septal defect from here because, as I've told you previously, in this particular window we are not aligned perpendicular to the structure, so this areas where you cannot see the septum are from dropout and there are not holes in the septum. You can diagnose a hole in a structure when you are perpendicular to that structure, not in line with it, like in this window. And using color Doppler, you can see the flow through the mitral valve in this case, because we are centered on the left ventricular and the left atrium. This is the mitral valve. So I said that the red color means that the flow is moving towards the transducer. So when we stop the image, we can see that there is laminar flow from the left atrium to the left ventricle through the mitral valve. So this patient has no mitral stenosis. The mitral valve opens fully in diastole. And the 5-chamber view that's obtained with an anterior angulation of the probe. The aortic valve becomes visible in this view and forms the 5th chamber. This is the apical 5-chamber view, as I've said. The aortic valve is in the center of the heart. This view is mandatory for the assessment of the severity of aortic stenosis. In patients with aortic stenosis, we measure the peak transvalvular velocity, a velocity of the blood traveling through the aortic valve from the left ventricle, and also the mean gradient and the peak velocity here below the aortic valve in the left ventricular outflow tract. And we use all these elements to quantify aortic stenosis severity. And the apical 2-chamber view, this is obtained with a counterclockwise rotation of the probe by 60 degrees. You can see the inferior wall here and the anterior wall. You can assess left ventricular contractility of these walls, and you can measure the left ventricular volumes for the Simpson's method for the estimation of left ventricular ejection fraction. So this apical 2-chamber view combined with the apical 4-chamber view, in which you can see the anterolateral wall and the inferior septum, you can assess the left ventricular ejection fraction using volumes, using this Simpson's method. The apical long axis view, the apical 3-chamber view or long axis view, is obtained from the apical 2-chamber view with a smaller rotation of the transducer. You can see the same structures as in the parasternal long axis view, the left atrium, the mitral valve, the aortic valve, the first segments of the ascending aorta, the inferolateral wall, and the anterior septum. You can also assess contractility of these walls here. And from these 3 apical windows, apical 4-chamber, 2-chamber, and 3-chamber view, you can see all the segments of the left ventricle and estimate the contractility of each segment. And this is important in patients with coronary artery disease, because when a patient has an infarction, for example, these scars are easily seen because those segments are not thickening in systole. The subcostal views. This is the long axis subcostal view, in which you can see the 4 chambers of the heart. The right ventricle here, this is the liver. This is the right ventricle, the tricuspid valve, the right atrium. The left ventricle, the mitral valve, and the left atrium. And the entrance of the inferior vena cava into the right atrium. This is used in patients in whom we cannot perform an accurate exam from the apical views, and it's more important in these patients because we can easily see all the 4 chambers from here. And it's also an important window in kids, in children, we can see the septum, the interventricular septum, the interatrial septum, and we are somehow perpendicular to these structures, and we can see if there are defects in the interventricular or interatrial septa from here. And as I've said, this is an alternative view when the four-chamber view is not feasible. And also, we can turn the probe by 90 degrees counterclockwise and obtain the same structures as in parasternal short axis view, with the aortic valve in the center, the right atrium, the right ventricular outflow tract, the pulmonary artery, and the left atrium here. But maybe the most useful, but this is the most useful section for seeing the inferior vena cava. You can see the entrance of inferior vena cava into the right atrium, and we measure these dimensions, the diameter of the vena cava, and also the variation in these dimensions with the inspiratory maneuvers. If there is a high pressure in the right atrium, the vena cava will become dilated and it doesn't respond to inspiratory maneuvers, and it's fixed. In this normal subject, it reacts to inspiration, to the inspiratory movements of the patient, and it collapses in inspiration. And the suprasternal views of you can see from the suprasternal notch the aortic arch here, and these great vessels, the innominate artery, the left common carotid artery, and the left subclavian artery, and also the descending aorta. This is a mandatory section in all patients, but it's most useful in patients with coarctation of the aorta. A comprehensive echo examination includes not only the 2D echo, this two-dimensional imaging has a key role because it gives you imaging of the structural findings that you can see in every patient. So it's most useful for diagnostic science and clues, but also you have to perform the M mode because this gives you additional information. This M mode helps you to see, because it has this high temporal resolution, and you can better see the movement of the structures of the heart, and you can align perpendicular to the structure to be able to measure it with accuracy. Modern echo machines have also this anatomical M mode, where you can align perpendicular to the structures in every possible direction that you have to do it. But the Doppler echo is very important because it gives you the hemodynamic information. We can measure velocities, we can measure volume flow, systolic and diastolic, and this Doppler echocardiography has a key role in assessing the valvular heart disease severity, as you will see in the courses afterwards. And it also detects the presence of shunts and the severity of those shunts. We have some important types of Doppler. We have the pulsed wave Doppler that localizes events and timing. We have the continuous Doppler that can measure high velocities, but without a spatial resolution. It can measure high velocities, so it's able to measure gradients for valvular heart diseases. And we have the color Doppler that's used for screening for regurgitation and stenosis and for the presence of intracardiac shunts. And we have the color M mode where you can obtain this imaging for flow timing. This is the color Doppler flow in a normal subject and this in a subject with mitral regurgitation. You can easily see that in systole there is a small turbulent jet here coming from the left ventricle to the left atrium through the mitral valve that does not close properly in systole. So in systole, the blood must flow from the left ventricle to the aortic valve, but not from the left ventricle to the left atrium. So this is a pathological element with a mild degree of mitral regurgitation. This is a short axis view at the level of the aortic valve. This is a short axis view at the level of the great vessels, but it's centered on the aortic valve in color flow Doppler. You can see this turbulent jet in diastole this time, with flow coming from the left atrium through the aortic valve and then through the aortic valve to the left ventricle. In diastole, this turbulent jet is a jet of aortic regurgitation. And you can also see it from here, this red jet coming in diastole from the aorta, from the ascending aorta, back to the left ventricle. So this is a pathological flow of aortic regurgitation. And you can also see what happens here at the level of the mitral valve, where you can see this blue jet, because it's away from the transducer, from the left ventricle to the left atrium through the thickened mitral valve. That's mitral regurgitation, because this particular patient had rheumatic heart disease affecting both the aortic valve and the mitral valve. Another image from a subject with a more frequent disease. This is the most frequent valvular lesion in adults, aortic stenosis. What you can see is that in systole, if I stop this image, in systole, you can see this turbulent jet at the level of the ascending aorta coming from a thickened aortic valve, because it's an obstacle here and the velocities are higher than normal, and this is a turbulent jet of aortic stenosis. This is a normal exam, as I've shown you earlier, the same normal subject, and also a normal color Doppler flow exam at the level of the aortic valve from the 5-chamber view. And this is a pathological exam. This jet, this blue jet, coming from the left ventricle to the left atrium in systole, is a jet of mitral regurgitation. And also in this patient too, an eccentric mitral regurgitation from the left ventricle to the left atrium. The pulsed wave Doppler exam allows the assessment of flow through normal valves. It localizes events, so we put this sample volume where we want to see the flow. This is the image of the flow in diastole. As you can see, this is the QRS complex, and this is diastole, and this volume sample is put just in the left ventricle, just above the mitral valve. So this is the flow coming from the left atrium to the left ventricle in diastole. It has two waves, two distinct waves, the E wave and the A wave. This is the early diastolic flow, and this is the late diastolic flow due to atrial contraction. And it allows us to assess the diastolic function of the left ventricle using the velocity of the E and the A wave and the ratio between the E and the A wave. And sometimes we can also measure the duration of this A wave. And this is a normal flow in the left ventricular outflow tract that allows the assessment of left ventricular stroke volume. This is a systolic flow this time, and the sample volume is put here at the level of the left ventricular outflow tract from the 5-chamber view. This is the aorta, the aortic valve here, and this is the sample volume here in the left ventricle. And you can see this triangular shaped envelope coming away from the transducer, so it's a negative envelope that allows us to measure the left ventricular outflow tract velocity and velocity time integral that allows us to measure the left ventricular stroke volume. This is the difference between a laminar flow, a normal laminar flow with normal velocities, and a turbulent flow with high velocities in a patient with mitral stenosis. So this is also a diastolic flow. The sample volume is put here above the mitral valve, in fact below the mitral valve in the left ventricle. It's above in the image, but it's below in the heart. And this is a turbulent flow with higher velocities than normally recorded in normal subjects. Because in pulsed wave Doppler, we cannot measure velocities above 1.5 meters per second. For higher velocities, we use continuous wave Doppler that can measure velocities up to 6 meters per second. And this allows us the assessment of flow through pathological valves. In this case here, it's also a normal valve. You can see this triangular shaped envelope in systole from the aortic valve. So this is the normal flow through the aortic valve in a normal subject. The normal aortic valve velocity is somehow below 1.7 meter per second, but localization of events is not possible by continuous wave Doppler. And this is the pulmonary valve flow, which resembles the aortic valve flow, also a systolic triangular shaped envelope here with lower velocities at the level of the pulmonary valve. Also, with continuous wave Doppler, we can measure the velocity through the tricuspid valve in systole. This is tricuspid regurgitation, and you can measure this gradient between the right ventricle and the right atrium, this systolic gradient. The higher the pressure in the right ventricle, the higher the velocity of this flow from the right ventricle to the right atrium. And we can estimate the systolic pressure in the right ventricle in this way. So this is the flow of through the tricuspid valve in systole in a patient with a mild tricuspid regurgitation. And in these images, the flow through the tricuspid valve, you can see that the flow is very turbulent and the jet is thicker. This patient had a moderate tricuspid regurgitation, and the velocities were higher because there were higher pressures in the right ventricle in this patient. The velocity is up to 4 meters per second here, and this, in this case, in this normal case, the velocity is between 1 and 2 meters per second. This is a normal velocity for this patient, and this is a pathological velocity in this patient. That signifies that the pressures in the right ventricle are very high. These are the normal values of flow velocities in a normal heart. You don't have to know them by heart, but just to have an idea about these velocities. These velocities are not higher than 1.7, maybe 2 meter per second in patients with aortic sclerosis, but the velocities are less than 1 or maybe 1.5 meter per second. So, if you have any questions. Do you have any questions regarding the presentation?
No, I don't think so.
I have one. Are we going to receive the PPTs with the videos?
Yes, I will send you the PowerPoint in this newer format where you can also have the videos.
And is there a book that you recommend for echocardiography? Because it is kind of new to us.
Yes, but you don't have to know how to interpret images in echocardiography. These lectures, the aim of these lectures is you to be familiar with echo, with these kind of standard views, to be able to follow us in the lectures that we will have later on, and the demonstrations, the practical demonstrations.
Okay, thank you.
The books are more than you can, more than you need for now. Okay, so I will send you the lecture with all the videos.
Thank you so much.
Thank you.
Okay,
Thank you.
Thank you. Have a great day.
Thank you.
Nice day.
Bye-bye.
Thank you.